welcome to episode 24 of ERRX. And in today's episode, we are doing an expert talks series, and we have with us today Dr. Casey Lee. Hi, Casey.
Hi, thanks for having me.
Absolutely. Thanks for being here. Would you just start off by kind of telling us about your training and what you're currently doing in your clinical role?
I graduated pharmacy school at the University of Florida back in 2014, which sounds a lot farther now than it used to, and did my PGY1 training at Beth Israel in Boston. Then I moved to Orlando, Florida. Florida's home for me, and started working in the emergency department at Orlando Regional Medical Center, where I practiced emergency medicine pharmacy for 3 years before deciding to go back for more. So I went back for a clinical toxicology emergency medicine fellowship in Jacksonville, Florida at the UF Health or UF Jacksonville Hospital and the Florida Poison Control Center in Jacksonville. And I just finished that, happy to say, this past summer and have moved back to Orlando. So I'm back at Orlando Regional again. Um, Hopefully, I'm picking up where I left off.
Perfect. Well, congratulations on all that training. And before we
Thanks.
started the episode, Casey and I had talked about I actually have lived in Jacksonville, Florida as well, and used to go visit before all this COVID stuff happened. It's a great area.
Yeah, lots to explore. It was fun.
Perfect. Well, let's get right into it. And the topic of today's episode that we're going to be discussing with Casey is methemoglobinemia. So, what is it? What drugs are used to treat it? And a bunch of other things. And we have with us, obviously, what I would consider kind of an expert in this field. So, I'll just kind of rattle off some questions and we'll have Casey share her knowledge with us.
All right,
So, Casey,
let's do
can
it.
you describe to us, chemically speaking, what is methemoglobinemia?
Sure. So when we think about methemoglobinemia, obviously that would be an elevated amount of methemoglobin in the blood. So hemoglobin, generally speaking, is our macromolecule that is responsible for oxygen transport. But it can be altered. There are different ways to alter that hemoglobin molecule. Methemoglobin is a form of hemoglobin that's been oxidized. So the heme iron configuration that's normally an Fe2 plus state is changed from that ferrous state to its ferric state. So, unlike normal hemoglobin, methemoglobin can't reversibly bind oxygen, which means that ultimately we have compromised oxygen delivery to the tissues. And normally, there are ways for the body to actually keep those levels of methemoglobin down to about less than 2% through its natural cytochrome B5 reductase system. But sometimes that can be overwhelmed, particularly in the setting of xenobiotics.
Absolutely. That is a great rundown of methemoglobinemia. And it's just interesting to know, like you said, that we actually have a natural defense mechanism against this. And I think I read somewhere that normally we run at a level of about less than 1% or 1% ish, but our body is able to compensate for that.
Right, exactly.
Perfect. So we're both pharmacists, obviously. So what are the most common agents or drugs that can cause methemoglobinemia? And also, are there some environmental factors or foods that can cause it? And then is it hereditary?
Yeah, so there are certainly hereditary conditions. Those are easy to knock out because there aren't too many of them. Those are
Sure.
typically going to be related to that cytochrome B5 reductase inefficiency. So, in patients who are deficient in cytochrome B5 reductase or patients who have an altered form of hemoglobin, hemoglobin M, those are some situations where you might see hereditary methemoglobinemia. As pharmacists, I think that we like to really hone in on some of those drugs that can induce it. So, the red flag drugs that will probably most pharmacy students will learn about would be things like local anesthetics. So benzocaine, especially among the local anesthetics, but certainly any of the local anesthetics. Dapsone is another key drug that has been implicated in many cases of drug-induced hemoglobinemia. Phenazopyridine, interestingly, I didn't really think too much about before I started the toxicology fellowship, but in some toddlers, even just a few tablets of phenazopyridine has caused clinically significant methemoglobinemia. Environmentally, certainly some of the nitrates that are involved in food processing, fertilizers, you can see those cause methemoglobinemia in patients who maybe are consuming well water, where that runoff may come into play. And then there are certain other chemicals, any of the nitrates, those are all going to be compounds that we think about as potentially causing methemoglobinemia.
Sure. Yeah. Very interesting. And the phenazopyridine actually caught me off guard too. That was one that I probably learned at some point during my education, but then had completely forgotten about.
Yeah, sneaks in there.
And
Snuck in
yeah,
there.
and exactly. And I mean, the big ones, for us, I mean, especially working in the ER, is I kind of think about those, the Cetacaine spray and, like you said, the
Right.
benzocaine sprays, and especially during those GI procedures. And that
Yeah.
was kind of new for me to learn because, whenever we verify that order for Cetacaine spray, it says, 1 to 2 sprays, and you don't think
Yeah.
much of it.
Standard dosing,
Um,
right?
Standard dosing, yeah. And we had recently a patient that came through our ER that was at a GI clinic and getting a procedure done and ended up having to be intubated. She actually coded, and they
Oh,
thought it was due to the
gosh.
Cetacaine spray and her developing methemoglobinemia. She was already a very ill woman, a lot of
Mm.
comorbidities. And I asked one of our ED providers, who also happens to be a fantastic toxicologist, like, how do you get methemoglobinemia from just 1 to 2 sprays of Cetacaine? And she just kind of looked at me like, that they use way more than just 1 to 2 sprays when they're doing these procedures. And I just had never thought of that.
Yeah, and it's interesting to think about. We don't really know what happens in a lot of those case reports that we get of those sprays being used or implicated in um, methemoglobinemia. But I think you described pretty much the worst case scenario is that you have
Yeah,
presumably a correctly used drug that goes on to cause very serious problems. It sounds like your patient had some other comorbidities that may have played into it, may
she
not have
did.
been extremely healthy at the outset. But interestingly, when I was going back over some of the literature for benzocaine specifically, it sounds like they actually did try to take a look at um, that dosing that might be used with benzocaine spray. In 2004, they did a review of 132 cases of benzocaine-induced methemoglobinemia. And interestingly, in 69 cases in which they actually described the dose used of benzocaine, 37 of those patients, so about 50% of those patients, had received just a single spray of benzocaine.
Wow.
So basically, what you described to me.
I mean, is that spray like just a 10-second long spray? I mean, there's something going on here, right? I mean, you
Yeah,
would
it's
think.
interesting. And benzocaine, really, out of the local anesthetics, is probably uniquely it's a uniquely predisposed drug to cause methemoglobinemia. It's metabolized to aniline, which is probably one of the original compounds which is noted to cause methemoglobinemia. So things like lidocaine and its metabolites, prilocaine, those all have metabolites that will behave similarly, but benzocaine, probably because of that metabolism to aniline, is probably the most likely to cause significant hemoglobinemia.
Oh, that's interesting. That's interesting. And then Cetacaine obviously is a combination that contains some benzocaine and some tetracaine, and I think there's
Hmm.
another one as well. So that definitely makes sense.
Right,
And,
right.
speaking of, I read somewhere that even chloroquine and hydroxychloroquine can induce methemoglobinemia at times, and which is interesting now in this COVID era, if we're going to see more cases of that, if more people are using hydroxychloroquine or if they're not. So that'll be
Yeah,
something interesting to
yeah.
watch too. I don't know if you've had experience with that or.
We'll have to keep our eyes peeled, and I'm sure some of those reports will be forthcoming as we look back at this early COVID era. I haven't really come across any recent reports of methemoglobinemia from how people have been using hydroxychloroquine lately, but I think it'll be something that we should probably keep our eyes peeled for.
Absolutely. All right. So when we talk about met hemoglobin levels, so how do specific levels correlate with signs and symptoms that a patient might experience?
So, actually, fairly well in most patients. Most patients who have low hemoglobin levels, so maybe something around the lines of less than 10%, a lot of those patients will be asymptomatic. So, we may never know that there was any instance of drug induced hemoglobinemia at all because they may not have any symptoms.
Sure.
As you move into the 20% range, patients start to become more uncomfortable. That's where they may have symptoms like headache, they may feel dizzy, may feel lethargic. And above somewhere between 20 to 30% is where you might start to see some of that cyanotic skin discoloration as well. So, our blue patients who receive our blue antidote. So, you'll start to see that around the 25 to 30% range. Once you hit the 40s and the 50s, that's where we see our very serious toxicity start to form. So the neurologic symptoms, cardiovascular collapse, seizures, shock. Those are all associated with higher levels, between 50% to 60% or higher, even in some very severe poisonings.
Interesting. And then that kind of leads me on to the next question in terms of, diagnosing methemoglobinemia. And when we talk about signs and symptoms, from what I understand, we have blood gases that can technically detect methemoglobinemia. Otherwise, other things actually don't help us in the diagnosis. For example, oxygen saturations or like your standard pulse ox. Is that correct?
Right. Yeah. So I think most emergency departments should have access to blood gas with coax, which will make that diagnosis a lot easier. But some of the clues could be just a kind of a persistently low SpO2 on that pulse oximeter.
Sure.
Pulse oximeters are pretty interesting, and there's some variability in terms of the machines themselves, but the methemoglobin actually will absorb at a wavelength that's very similar to deoxyhemoglobin. So that's why patients with significant methemoglobinemia can look cyanotic, have that chocolate brown characteristic textbook phrase blood color.
Hmm.
Um, very, very high hemoglobin levels will cause the pulse oximeter to trend toward 85%. And that's because the methemoglobin absorbs red and infrared light, which the pulse oximeter depends on, equally well. So the R value, which is basically a ratio of red and near infrared light, so that'll actually correspond to an SpO2 of 80 to 85%. So when we look at the pulse oximeter, it becomes very unreliable in patients with either mild or very severe methemoglobinemia because their actual oxygen saturation may either be very much worse than what we're seeing, or it could actually be better.
Interesting. It's very interesting. And if we have obviously a patient with the methemoglobinemia, what are some tried and true treatment options?
So the most widely accepted treatment for methemoglobinemia, of course, is going to be our methylene blue, our blue antidote for our blue patient.
I like that. I like that.
So
I'll have to remember
yeah,
that.
that's the favorite for the med students and the pharmacy students coming through that they never forget. So methylene blue is a great drug. It's an old drug. Originally had been used as an antiseptic, but it was actually back in the 30s that it was first used for aniline-induced methemoglobinemia. So it's dosed at 1 to 2 milligrams per kilo of body weight. Most people will start at about 1 milligram per kilo. And that's given over 5 minutes to lessen some of that injection site pain. So the way this works is it enhances the activity of NADPH methemoglobin reductase, and ultimately will bring your oxidized ferric state back to its ferrous state of methemoglobin. So it takes us back from the Fe3 plus to the Fe2 plus state, so that hemoglobin can then again carry oxygen correctly. I think it's probably one of the most interesting drugs that we can dispense in the pharmacy because it is such a very deep, pretty shade of blue.
Hmm.
Um, and I think one of the biggest things to note here is that you can repeat a dose if you see a partial improvement. Although larger doses are unlikely to be beneficial and actually may contribute to your problem and cause things like hemolysis. And in some cases, when given with other agents like serotonergic agents, have also been implicated in serotonergic toxicity and other adverse effects.
Yeah, that's a great point. And so, to be clear, when we talk about methylene blue and we talk about using methylene blue, it's my understanding that we usually don't use it unless levels are somewhere around 20% or greater. Or if you have a patient that's compromised with lower levels, that would be an indication for methylene blue. Is that kind of your takeaway from it as well?
Right. So sometimes you'll get these patients who come in, and you may either incidentally or because of your clinical suspicion get a blood gas with co-oximetry and identify that they have an elevated hemoglobin level. But if they're asymptomatic, then generally those patients don't need methylene blue. Or if patients are very mildly symptomatic, they may benefit from some supplemental oxygen. and not necessarily need treatment with methemoglobinemia. Generally, you won't see patients with a level less than 20% needing treatment with methylene blue,
Sure.
but there's certainly, based on the patient's clinical presentation, if they're very symptomatic, out of proportion to what we'd expect from that level, it's still worth that challenge.
Great. And I know you had mentioned, that potentially it can cause or contribute to serotonin syndrome in patients that are taking serotonergic agents. Um, Tell me a little bit about, if you can, in the setting of G6PD deficiency and the controversy there with using methylene blue in these patients.
Right. So there's two concerns with patients who are G6PD deficient. I think a big concern would certainly be hemolysis, and those patients might be more susceptible to hemolysis after use. Probably the more common and the bigger issue, it would be that it wouldn't work. So G6PD deficient patients wouldn't be able to convert NADP to NADPH, which is
Sure.
actually needed to convert methylene blue to its leukomethylene blue form, and that leukomethylene blue is actually responsible for the reduction of Fe3 plus to Fe2 plus. So, yes, risk of hemolysis, but even more so, we're not likely to see a good response from those patients who are G6PD deficient.
Great. Very, very interesting stuff. All of it. Is there any tips or tricks for giving methylene blue? I know personally I've only seen it given once or twice. Actually, the first time I've ever seen it given, it was more for vasoplegia for a patient that was on, three or
Right.
four pressors. But I've never really given it for this indication in my, few years in the ER. Have you personally given it? Are
Right.
there any tips and tricks with giving it? Any side effects we should watch out for?
Yeah, only I've over the phone recommended it more often than I've actually dispensed it, which I think has been once in 5 years.
Sure.
They don't actually walk in through our doors super often, but I think the most important things to know are that um, the the local response is probably the most uncomfortable side effect for patients. A good IV and a good flush afterward will help diminish some of that infusion site pain that can happen sometimes with methylene blue. Otherwise, it's generally pretty well tolerated. There are some reports that you might see a slight dip in the pulse ox reading because of the methylene blue's actual its own intrinsic absorbance. Haven't personally seen that happen or had anyone describe that. You should see improvement pretty quickly. So if you don't see good improvement within the first 15 minutes, then you can re-challenge. Maybe think about whether it was enough of a dose and re-challenge. I'd probably just go with another 1 milligram per kilo, or think about other reasons why the patient might be cyanotic.
Sure. Great point. Well, that about wraps it up on my end. Do you have anything else that you would want to add or anything you want to circle back to?
No, I think it's a really great topic and definitely one where pharmacists are very useful in kind of reviewing possible agents that could be causing it. It's a very enjoyable disease state because it responds very well to therapy.
Yeah, yeah.
So,
It's always
kind of a
gratifying.
fun one. Yes,
Yeah,
very gratifying.
absolutely. Well, thank you, Casey, so much for your time and for your expertise in this disease state. Well, I really appreciate having you on.
Absolutely. Thanks for having me.